Welcome to this Step 3 review on contraception and reproductive health. This video is brought to you by Roadmap to Residency. Our goal today is not to reteach every detail of reproductive medicine. It is to show you how the question stems are built around contraception and infertility, and how to attack them efficiently. We will look at contraceptive counseling, placement of intrauterine devices and implants, emergency contraception, and the initial workup for infertility. For each one, we will focus on the high-yield clues in the question stem and the test-taking strategy that gets you to the right answer fast. Make sure you are also working through your question bank and a solid review resource alongside this video, because these patterns are best learned by doing many practice questions. Let us get started. Here is what we are going to cover today. First, we will learn how to approach contraceptive counseling questions by reading for what the patient values and which medical conditions make a method safe or unsafe. Second, we will master the timing and safety checks behind placing intrauterine devices and implants, and the rules for emergency contraception. Third, we will recognize when an infertility workup actually begins and which partner should be tested first. Along the way, we will walk through several practice questions together and explain exactly why each answer choice is right or wrong. This video assumes you have baseline knowledge from your review resources. We are here to sharpen how you take the test. Our first strategy is for contraceptive counseling questions. The credited answer almost always matches what the patient says she values, so read for her priority. If she wants the most effective method or hates the idea of remembering a daily pill, the long-acting reversible options, meaning the intrauterine devices and the implant, rise to the top. If she is planning pregnancy in a few months, you want something quickly reversible. The second half of the strategy is just as important. Before you ever choose an estrogen-containing method, scan the stem for contraindications. Migraine with aura, a smoker older than 35, a prior blood clot, uncontrolled high blood pressure, or current breast cancer all steer you away from estrogen and toward a progestin-only method or a copper device. Test writers plant exactly one of these clues to see if you will catch it, so train yourself to look every time. For the underlying eligibility details, lean on the medical eligibility criteria chart in your review resource and your question bank. Strategy 2 covers placing intrauterine devices and the subdermal implant, and the test loves two specific moves here. First, before placement, the one thing you absolutely must confirm is that the patient is not pregnant. If you cannot be reasonably sure, the next step is a pregnancy test. Resist the distractors that order routine cervical cultures, screening pelvic ultrasound, or a separate follow-up visit before placement in an otherwise healthy patient. Those add cost and delay without benefit. Second, once pregnancy is reasonably excluded, the credited answer is usually to place the device at that same visit, which is called quick start or same-day placement, rather than sending her away to return during her period. And remember the special case. If a patient had unprotected intercourse within the last 5 days and wants the most effective emergency option that also continues as birth control, the copper intrauterine device is the standout answer because it does both. For the eligibility and timing specifics, review the contraception chapter in your review resource and drill the device questions in your question bank. Strategy 3 is emergency contraception, and the whole game is reading the timeline and the small details. First, anchor on the time window. The very first thing to find in the stem is how long ago the unprotected intercourse happened. The copper intrauterine device and the prescription ovulation delaying pill both work for up to 5 days. The over-the-counter progestin pill works best within 3 days and weakens after that. Second, match the method to the detail. The copper device is the single most effective option and is the standout when she also wants ongoing birth control. The ovulation delaying pill works better than the older progestin pill in patients with a higher body weight. If she just wants the simplest same-day pill and is early in the window, the progestin pill is fine. Third, do not delay or overtest. A pelvic examination, cervical cultures, and even a pregnancy test are not required before giving emergency contraception, and insisting on them first is the classic wrong answer. The one nuance to remember is that after the ovulation delaying pill, you wait a few days before starting regular hormonal contraception, so it does not interfere. Drill these timing rules in your question bank and confirm them against the contraception section of your review resource. Let us work through our first practice question, and this one is built to test contraceptive counseling. A 32-year-old woman comes in to discuss birth control. She tells you two things that matter most. She wants the most effective method available, and she is bad at remembering a daily pill. Then the stem plants the safety clues. She has migraine headaches with visual aura, and she smokes about half a pack a day. She has no children yet, and wants to keep the door open to pregnancy in a few years. The question asks for the most appropriate recommendation. As you read the four choices, hold on to two ideas at once. What does she value, and what is unsafe for her? Pick your answer now, and we will walk through the reasoning together on the next slide. Let us break this down step by step. First, spot the pattern. She told us exactly what she values. She wants the most effective method, and she does not want a daily pill. That combination points straight at a long-acting reversible option, meaning an intrauterine device or the implant. Then the stem planted two safety clues, migraine with aura and heavy smoking, and both of those make any estrogen-containing method unsafe. Second, apply the rule. The progestin-only, or levonorgestrel, intrauterine device hits every single thing she asked for. It is among the most effective methods. There is nothing to remember daily. It contains no estrogen, so it sidesteps her contraindications, and it is quickly reversible when she wants to conceive in a few years. So the answer is choice B, the levonorgestrel intrauterine device. Third, eliminate the wrong answers. Choice A, the combined pill, and choice C, the patch, both contain estrogen, which is unsafe with migraine with aura and smoking over the age cutoff, so they are out. Choice D, condoms alone, is far less effective and ignores her request for the most effective method. Notice how reading for her priorities and then screening for contraindications walked you right to the answer. Here is our second practice question, and this one is about what you must do before placing a device. A 26-year-old woman comes in asking for a contraceptive implant in her arm today. Two details matter. Her last period started 3 weeks ago, and she had unprotected intercourse 2 days ago. She has regular cycles, no medical problems, and a normal examination, and she is sure she wants the implant. The question asks for the most appropriate next step before placing it. The trap here is that unprotected intercourse 2 days ago means you cannot simply assume she is not already pregnant. Scan the choices and think about which single step actually has to happen before placement, and which ones are unnecessary tests that just add cost and delay. Pick your answer, and we will reason through it on the next slide. Let us work through this answer. First, the one required step. She had unprotected intercourse 2 days ago, so you genuinely cannot be sure she is not already pregnant just because her last period was 3 weeks ago. Before placing the implant, you perform a urine pregnancy test. If it is negative, you place the implant that same day using Quick Start, and you tell her to use a backup method, such as condoms, for the first week. So the answer is choice A, the urine pregnancy test. Now, why do the other tests fail? Choice B, routine cervical cultures, and choice D, a pelvic ultrasound, are not required before placing an implant or an intrauterine device in a healthy patient. They add cost and delay with no benefit, which makes them overkill traps. Choice C, scheduling placement during her next period, is the old way of thinking and needlessly leaves her unprotected for weeks. Same day, quick start placement is preferred whenever pregnancy can be reasonably excluded. The correct answer is the urine pregnancy test. Strategy 4 is the initial infertility workup, and the test rewards 2 clean moves. First, check the clock before you order any test. Infertility is defined as failure to conceive after 12 months of regular unprotected intercourse, so the default is that you do not begin testing until a year has passed. The single most important exception is the woman's age. If she is 35 or older, you start the workup after only 6 months, because time matters more. So if a STEM describes a young couple who has been trying for just a few months with no warning signs, the correct answer is reassurance and continued timed intercourse, not a workup. Second, once testing is due, test both partners at the same time, and start with the simple things. The highest yield first test overall is a semen analysis for the male partner, because it is inexpensive, non-invasive, and catches a very common cause right away. For the female partner, you confirm that she is ovulating, often with a mid-luteal progesterone level. The study that images the fallopian tubes comes later, after these simpler tests. So favor the answer that begins with the semen analysis and an ovulation check. Reinforce these definitions and the testing order with the infertility section of your review resource and plenty of question bank practice. Here is our third practice question, and it puts the emergency contraception strategy to work. A 24-year-old woman comes in after a condom broke 4 days ago. She does not want to be pregnant and asks for the most effective option, and she adds that she would like reliable, ongoing contraception going forward. Her examination is normal and her pregnancy test today is negative. The question asks for the most effective recommendation. 2 details should jump out. First, it has been 4 days, which is inside the 5-day window, but past the best window for the older over-the-counter pill. Second, she wants ongoing contraception, not just a one-time fix. Hold both of those in mind as you read the choices. Pick your answer, and we will reason through every option on the next slide. Let us break down this answer. First, put the 2 clues together. She wants the most effective option, and she wants ongoing contraception, and she is still within the 5-day window after the condom broke. There is exactly one choice that satisfies all of that at once, and it is the copper intrauterine device. It is the single most effective form of emergency contraception, clearly better than any pill. And the moment it is placed, it becomes highly effective birth control that lasts for years. So the answer is choice A, the copper intrauterine device. Now, why do the pills fall short here? Choice B, the over-the-counter progestin pill, is the least effective option and works poorly this far out at 4 days. Choice C, the ovulation-delaying pill, is actually a reasonable pill within 5 days and is a good distractor, but it is still a pill, it is less effective than the device, and it does nothing for her stated wish for ongoing contraception. Choice D, starting a combined pill tomorrow, does not address the unprotected exposure that already happened, so it is not emergency contraception at all. The correct answer is the copper intrauterine device. Notice how reading for the time window and her ongoing goal pointed straight to it. Here is a high-yield pearl that ties the infertility material together into a fast decision shortcut. Whenever you see an infertility stem, ask 2 questions before you even look at the testing options. First, how long have they been trying to conceive? And second, how old is the woman? If they have been trying for less than a year, and she is younger than 35 with no red flags, the workup is not due yet, and the correct answer is reassurance with continued timed intercourse. If they have been trying for a full year or for 6 months when she is 35 or older, then the workup is officially due. Once it is due, remember the second half of the shortcut. Test both partners at the same time, and lead with the cheapest, simplest tests. The semen analysis is the standout first test for the male partner, and you confirm ovulation in the female partner, often with a mid-luteal progesterone level. The study that images the fallopian tubes comes later, after those simpler tests. Asking how long and how old, then testing the easy things first, will steer you to the right answer on almost every infertility question. Lock these rules in with your review resource and your question bank. That wraps up our review of contraception and reproductive health for Step 3. Remember the core strategies we covered today. For contraceptive counseling, read for what the patient values, then screen for the estrogen contraindications hidden in the stem. For placing devices, confirm she is not pregnant, then favor same-day quick start placement. For emergency contraception, anchor on the time window. Remember that the copper intrauterine device is the most effective option and continues as ongoing birth control, and do not delay care with unnecessary tests. And for infertility, ask how long they have been trying and how old she is. Then test both partners starting with the simple semen analysis and ovulation check. The best way to lock all of this in is to drill questions in your question bank under timed conditions and read every explanation, even on the ones you got right. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.